name's Grainne O'Kane. I am a medical oncologist at St James's Hospital. Fairly recently returned home from Canada, although I keep saying that and then I'm realizing I'm nearly 2 years home. But it's really good to be back in Ireland where people can pronounce my name. Usually I'm introducing myself and no one has any idea. It's usually Greally that is being called. So a little bit of background for me before I introduce Derek, who's one of my colleagues and a consultant medical oncologist at Cork. So first of all, when I was in Canada, patient partnerships with oncologists were very strong. And it's one of the striking things in Ireland when you come back as a medical oncologist. The relationship is still a little bit different, which is why I absolutely loved when Patricia reached out and this initiative and the Irish Colorectal Cancer Community Group were there. I think it's so important. And the importance of today is for us as medics, and there's quite a few medics here, is to really hear your voice. You will tell me that in the clinics we're rushing you through and you barely have time to sit and someone else is being brought in. So the patient voice is so important, and what you want from your healthcare providers along the journey from pre-diagnosis, diagnosis, treatment, and survivorship. And I know we're going to hear from some patients today, which is really important, but we need to hear that too. And never be afraid to challenge your doctors and give them advice. When I say that, yeah, people say, I'm never going to challenge my doctor. But you know, the world is changing and it is much more of a partnership. And I think that's really important. We're here predominantly today because of early onset colorectal cancer. So you'll see a lot now of EOCRC. It's becoming a proper term, and that really defines people under the age of 50. And we'll hear from some of our specialists and those who are interested in this area from a research perspective today. This is becoming a huge issue globally, and it's global. And so I listened to a surgeon recently in North America giving a podcast about early onset colorectal cancer. And he said 30 years ago, I don't have that 30 years ago experience, but he used to say, you know, I never saw anybody under the age of 50 in my clinic. And now I'm seeing so many of my patients under the age of 50. And we heard Mary talking about 1 in 10 under the age of 50. Those with colorectal cancer, 1 in 10 are under the age of 50. In America at the moment, they're quoting that those under 55 with colon cancer, so there's 1 in 5 under the age of 55 with colon cancer. So what's probably going to happen is we're going to see much more of this. And today is really about trying to create an awareness of that. This is all new to all of us, to all healthcare professionals, and we are recognizing that it's a problem. And absolute kudos to the Irish colorectal cancer community for really leading this and beginning to create this awareness. And Patricia mentioned she'll hope this will continue. It for sure will continue, absolutely no doubt. So I am going to
move. Just before, actually, I didn't have something about it for you, sorry, but the Cork connection. I mean, I went to.
I don't have one of those. I'm from the north.
I know we are in Cork. I went to events that had a very deep had with Seamus O'Reilly. And you see, that wasn't, I was like, because I went to the research literature to kind of see how these things have run. And I looked at Seamus at the end and I said, Seamus, to this component. Is Derek here? Derek here. So I hope Shane, you won't be upset now by this time. But anyway, Seamus said, I screwed in.
Oh, yes,
he's back from Canada. I think I'd be really interested. So that's also like how important it is to ask people to ask. Like always, people have been just so generous with their time and their everywhere. You know what I mean? So it's Seamus.
No, you will hear. We all are very, very interested in getting patients involved, and it is so important. And I have to say that Canadian experience is very, and many of our charities will tell us that we look to the Canadians a lot. That it's historical there for a number of years that patients are involved in absolutely everything. One fun fact before I go is that I went to the Dairy Girls School. I might not sound like it. But okay, next, let's see. I have the pleasure of introducing Derek Power, who is a fantastic colleague, and I know someone who is very dedicated to the patients. So Derek graduated from Trinity in 1994, initially with pharmacy, and then went on to RCSI to complete his medical degree and complete his medical oncology training at Memorial Sloan Kettering. And then was appointed in Cork as a consultant medical oncologist and has a specialist interest in both GI, GU, and melanoma. He is obviously well published, over 100 citations in the literature, and has written 5 book chapters. Derek is also instrumental in clinical trials in Ireland and has been a PI, a principal investigator that is, in a number of studies, and has also been awarded a grant for looking at gut microbiome and neuroendocrine axis in pancreatic cancer. So he was also appointed as an honorary clinical professor in UCC in 2022, which I've no doubt is very much deserved. So I'm very excited and have the pleasure of introducing and bringing Derek to the stage. And he's going to give us a wonderful talk.
Hi everyone. So I'm Derek Power. I'm an oncologist in Cork. I work in CUH in the Mercy. Thank you all for coming, and thanks to Helen, Jane from the Marie Keating Foundation, and to Grainne for all the kind words. So it's a real pleasure to talk to you about this topic of colorectal cancer. So I'm a medical oncologist. Obviously, what I do is I give drug treatment for cancer, colorectal cancer in this case. So I'm going to try and set the scene a little bit about our country with colorectal cancer, the numbers, who looks after the numbers, how common it is. I'm not a surgeon. I'm not going to talk about surgical treatment. I'm not a radiation doctor. I see Dr. Paul Kelly, my colleague, is here. He might talk about that later in the discussions. I'll allude to those specialties. So this is a true multidisciplinary management of this disease, but I'm going to focus obviously on the drug treatment and the developments and a few other tangential discussions about young patients who are developing this disease, about newer treatments. Maybe I'll touch on survivorship. Thankfully, many of our patients, some of whom I see here, are surviving, cured of bowel cancer. So that's very important to stress as well. So it's hard to get all this into 30, 40 minutes. So this is a bit of a whistle tour stop. So I hope you'll find it interesting.
Derek,
So,
just ask a question for a second.
Yeah.
Do you want to leave time for questions at the end, or
At the end would be
or-
great, yeah, or you want to do it at the very end, the panel discussions might be better,
Yeah, so-
because, you know, inevitably these things run over, don't
Yeah.
they? So it's better probably just to get through.
Sure.
So we have a cancer control program in the country. You can go onto their website. It was founded a little over 15 years ago, 2007. Very good website to go to. This is how we organize cancer. And if we organize cancer treatment properly in Ireland, patients, all of us, maybe patients in the future, will do better. So that's what we're trying to do in the country. And unfortunately, cancer is increasing a lot in our country. This is actuarial data from the HSE and the NCCP, and you don't need to be a scientist to see that the graphs are going up and up over time. There is more cancer. That's a whole topic of discussion in and of itself, but just to make the point, it's becoming more common. So we have the National Cancer Screening. Actually, do you know what? I think my slides are all, they're skipped. There's multiple slides skipped here. They're all out of sync. They come because I have whole talks on the bowel screen and everything. I seem to have skipped. Anyway, I'll go on. I could have uploaded it myself. Anyway, I'll go on. So there's a few things skipped here. So we have a, actually there's a lot of slides skipped. But anyway, I'll go on. Yeah, will you check them there?
Yeah, I have them on my.
Yeah, because there's several slides not there. I had talks on the cancer screening. I can get your memory stick.
No, I have it on. I have it on.
Yeah,
It's still here.
yeah, but okay, great. Sorry about that. Yes, that's it. Yeah, that's it. I don't know what happened with the other one. No problem. Yeah.
Well, we're on track.
Yeah, great. Anyway, yeah. So that's the cancer control program. And we also have a cancer registry. And we're in Cork, obviously. The cancer registry is in Kinsale. Again, this is a website you can go onto. It's freely available. And the purpose of the cancer registry is to tell us where cancers are happening in Ireland. It doesn't tell us why, but it gives us facts as to where cancers are happening. So this is part of the cancer registry called a cancer atlas. It maps where cancers are in the country. And this, alarmingly, is the map of our country, and anything dark purple is more common than the average, which is green. So dark purple is up to twofold and higher, more frequent than the rest of the country, in this case, in colon cancer. So you can see we're living here in Cork and Kerry, it's Waterford, in a hotspot for bowel cancer. Again, I don't know why that is, but that's a fact. And you can see as well here, this is all cancers that are mapped according to frequency, significantly high, and not significantly high. And again, you can see in this part of the country, there's a lot of cancer, more per 100,000 of our population than anywhere else in the country. And again, I don't know why. Maybe we might talk about that at the end. So we have projections for cancer. I've mentioned this, I won't go through this. This is where the slides were skipped, so I apologize about that. So we have a cancer strategy. We've written 2 of them. The first one finished in about 2015-16, and this is the second one. Professor John Kennedy, who is a fantastic medical oncologist who's now kind of semi-retired. He was my mentor in St. James's. Ronnie knows him well, Paul Kelly no doubt knows him well. He's the author of this cancer strategy. And this puts together how, as a country, we decide to manage cancer, diagnostics, infrastructure, etc. So again, freely available on the internet if you want to read it. So we also have a cancer screening service, NCSS, and we screen for 3 cancers in our country: breast, cervical, and bowel. There's been a lot of controversy in recent times about one of those cancers, but I'm emphasizing very strongly that screening works. Screening absolutely works. Screening can pick up cancers that are asymptomatic, no symptoms, and also can cure these cancers. So with respect to bowel cancer, we have bowel screen. I won't go into this in great detail, but anybody who's a citizen of our country between the ages of 60 and 69 is offered this, not over 69, because most people should have a colonoscopy at that point anyway, and not under 60, or so we thought. And Grainne has alluded to this, and other speakers will allude to this, that unfortunately this cancer is becoming a lot more common in under 60s. So we're behind the curve in Ireland in terms of our bowel screen. In the United States, I think it's down, what, to 55, 50, 45 even. So, I mean, there's huge resource implications to that and so on. So I think the government and the health bodies are looking into this as we speak at the moment. So this was introduced, bowel screen, in 2013. The aim was to reduce mortality from bowel cancer. And very, very briefly, here's some of the interim results. And out of every 1,000 people screened, about 2.5 cancers are picked up. And the staging of cancer, how advanced it is, has shifted from advanced stage to earlier stage. And that's what you want with screening, because the chances of cure with an earlier stage cancer, i.e. 1, 2, and 3, is much higher than with the later stage. You can still cure the later stage, but we've shifted the stage because of screening, and that's obviously a good thing. Screening works. Please do the screening. And the website is very good for bowel screening, freely available. So bowel cancers are rising. Why? We don't know. There's an awful lot of theories. There's an awful lot of discussion. Why is this? And very worryingly, it's happening a lot in young people. And we've known this for a few years. A lot of people have published on this all over the world. Some of our speakers later trained in the US, where I trained, have worked in units that have specialized clinics for young patients with bowel cancer that have no family history, that appear to be getting this for no discernible reason. So nobody knows why, really no one knows why this is happening, but it really is happening. I'm working as a consultant in Cork almost 13 years. And for the first 6, 7, 8 years of my career here, I would see a lot of bowel cancer because I've been interested in it, obviously. I hardly saw anybody under 50 without a family history. Now, as was mentioned by Patricia and Grainne, it's about 20% of cancers that we see are under 55 with bowel cancer. So why? I don't know. There's talks about links with obesity, about links with high antibiotic use as a child, many other things, but none of these are proven. So what about risk factors for cancer? This is relevant. Many of us would guess at this anyway. And the reason I stress this is there's an awful lot of myths in the community about what constitutes a risk factor for cancer and what doesn't. So we looked at this with UCC and we published a survey on what is the public's perception of a risk factor for cancer. And you need to be very, very careful about understanding what's a risk factor. Red wine, for example, is not protective against cancer. We all like red wine. Red wine is alcohol. If I'm being very puritanical about it, alcohol is a toxin. It's a carcinogenic. If you look up the World Health Organization website for risk factors for cancer, which is quoted in this paper, you will see avoid alcohol. and we all drink, me included, but you'd be amazed at the myths that are out there. I mean, if you look at what's seen here, myth or misconception, what people, members of the public, think causes cancer. Stress actually prevents cancer, believe it or not. Patients with type A personalities get less cancer. So mobile phones, there's no proof they cause cancer. This is another talk in itself, but I'm just stressing that be very careful going on fad diets and all of this, protecting cancer. You know, these things invariably are rubbish. And the reason I stress this again is that there are as many of you in the audience, maybe, certainly many of my patients, develop cancer for no discernible reason. I mean, the term bad luck may seem a little bit crude to use, but I see so many fit patients with no discernible risk factors, non-smokers, minimal drinkers, fit, healthy, medical colleagues I see who are very fit, who get cancer, bowel cancer. So this is a paper very briefly looking at risk factors for cancer and what's modifiable. I don't normally put up slides with lots of words on them, but with this very, very briefly, 42%, it's estimated, of all cancers are attributable to modifiable risk factors. So what we do to ourselves, smoking, overweight, no exercise, the wrong foods, etc., which of course means the majority may just happen. So it should always be on your radar that cancer is a possibility if you have symptoms. And also, please remember, a lot of cancers, they just happen. You didn't do it to yourself. It's nobody's fault. It just happens. There is a randomness to this also, which is a little bit nihilistic to say, but it's a fact. So here's some of the cancer fact sheets on bowel cancer from the Cancer Registry. I won't delay on this. There's about 3,000 of these cancers in Ireland per year. Our average risk in our lifetime is approximately 1 in 20, maybe 1 in 30. And it's the, I think it's the second or third most common cancer in our country per year. Most of the cancers still occur in the 60 to 69 group. We've mentioned about the younger group being more common. And these are the classic risk factors that are listed here, and I mentioned them earlier. The stage is very important because earlier stage, if cancer is picked up earlier, invariably with any solid tumor cancer, cure is much more likely. So here's how the stage is broken down in our country according to percentages from the National Cancer Registry. So how do I get involved in treating cancer? Well, I'm part of a multidisciplinary team. So no one person can treat cancer anymore. This was historic, but this is not the case now. You need to go to a hospital that has a multidisciplinary team with all these specialists who have their specialist interests in what they do. Not every doctor knows everything, which was the case years ago erroneously, and thank goodness it's not the case now. And when I look at multidisciplinary team, a critical part of this are our nurse specialists, our dietitians. I'm married to a dietitian, an academic dietitian. Huge role to play in cancer. And again, there's a lot of myths about diet. I'm not going to go into that. We might talk about that later, but it's super important. And psycho-oncology as well. I mean, I can only imagine the grief reaction that patients have when diagnosis is given and when prognosis is discussed. And this was ignored by oncologists and surgeons years and years ago. And thankfully now we have a whole other specialty that can help deal with this in a coordinated way. So the patient is the center of all of this, and all of these specialties feed into the patient. What symptoms do you look out for? I was hoping there might be a gastroenterologist on the agenda today, but there isn't. So I guess I'll briefly talk about the symptoms. I cut and pasted this from the American Cancer Society. I'm not going to read it out word for word, but I think many of us are aware: a change in bowel habit, change in the color of your stool, abdominal pain, losing weight, which can be somewhat non-specific, as can fatigue. But any of these symptoms, please don't ignore them, because if something is picked up earlier, as I've said, the chances of cure is higher. So early stage bowel cancer is so-called stage 1, 2, 3. The treatment of choice for this, and the most important person in this management, is the surgeon. So surgery for early stage disease is nearly always done. Very rarely you can remove malignancy from the bowel in a polyp with a scope. That's rare, but in most cases, part of the bowel is removed. Maybe some lymph glands are positive, but the critical intervention is surgery. And what about chemotherapy that I do? Well, we give chemotherapy to patients with early stage disease who have positive lymph nodes invariably. And the number of lymph nodes is important. We didn't know this years ago. Now, if there are 3 or less lymph nodes, in most cases, we give 3 months of chemotherapy. If there are 4 or more lymph nodes, we tend to give 6 months. I acknowledge there's age considerations, comorbidity considerations, etc. But generally speaking, that's what's done. I put this here because this is a port. There may be some patient in the audience with ports. These are internal access device to veins. You can lead a normal life with the port. It can stay there temporarily or permanently. And I think these have transformed the way we give chemotherapy. So what about rectal cancer? So bowel cancer is a generic term for the rectum and the colon and even the appendix. So colon cancer is higher up, about say 15 centimeters up from the back passage. That's colon cancer. So rectal cancer is 15 centimeters and below. And the management of rectal cancer, as some of my colleagues will no doubt say, is a little more complex, to put it mildly, than the management of colon cancer. So you would invariably never have surgery for a rectal cancer as an initial intervention. Invariably, you would have a combination, either concurrently or in sequence, of radiotherapy, of chemotherapy. And sometimes these interventions are so good that there's even move afoot now to not do surgery on rectal cancer in select numbers of patients who have such a good response. Because the difficult thing is with rectal cancer is because it's so low down in the bowel, there may be stoma bags involved. There invariably is. These may be permanent. There may be nerve damage from the surgery. There may be bladder damage from the surgery. There may be sexual dysfunction, side effects, etc. So this is a complex, difficult surgery. And there are few surgeons in the country that do this expertly. And the Cancer Control Programme, which is why I put this up first, have coordinated healthcare systems around the country to make sure the right surgeons are doing these operations. So what about advanced bowel cancer? Well, this is even more complex. So when I say advanced, I mean, unfortunately, the disease has moved from the bowel to other places away from the bowel, like the liver, like the lung, like any other organ you care to mention. So treatment here is complex. And historically, as I'll talk about in a moment, this was incurable. But now, in significant percentages of patients, cure is very realistic. And I have many patients, I'm privileged to have patients who are living 9, 10, 12 years and more. Patients are in the audience who are living with bowel cancer, hopefully with a good quality of life. And this is not a fatal disease anymore for a significant percentage of patients. So treatment is complex. Do we remove the primary tumor or not when the disease has gone to other places? Sometimes we do, sometimes we don't, depends on where it is and if it's causing symptoms, etc. Can advanced disease be removed? I mean, what's one of the most powerful things in modern medical oncology from my point of view is if bowel cancer has spread to the liver or the lung, you could remove this and cure the patient. I mean, who would have thought this 30 years ago? Radiology is very important. I put up some PET scans here just for illustrative purposes. We have fantastic radiologists now all around the country, and obviously I know them very well in Cork and multiple hospitals. They can do all types of things now. They can burn away tumors, they can embolize, block off blood supply to tumors, fancy scans like PET scans and everything. So radiology has really changed things an awful lot. Chemotherapy is obviously involved in bowel cancer. We have drugs now that are given in addition to or instead of chemotherapy. And these drugs are called biologic or targeted therapy. And a hot topic in my world is immunotherapy. I'll talk about that in a moment. So I'm not going to get too technical here, but I have to be a little bit technical. There are a load of drugs for advanced bowel cancer. And these drugs fit into a jigsaw. It gets incredibly complex. And many of you in the audience may have had 1 or 2 or 3 of these drugs in combination. Maybe only 1 of them, maybe 3 of them, maybe in sequence, maybe over years. And these drugs have really changed how we manage bowel cancer. Again, I'm not going to be too technical. Some of them inhibit blood vessels, and they're called these drugs here. We don't know how really to monitor these. We don't have any markers, but we have other drugs called EGFR antibodies. These target specific aspects of cancer cells and inhibit pathways that are involved in carcinogenesis. So all these drugs are given in sequences like this. And years ago, I suppose as recently as 20 years ago, the average survival for advanced bowel cancer was about a year. Now the average survival can be up to 3 years, and that's average. That's some poor patients who have really advanced disease at presentation, and then other patients who can live for 10, 15 years ongoing. So an average survival is a very mixed figure. It's a heterogeneous population. So CRC stands for colorectal cancer. So very briefly, 50% of patients with bowel cancer at some point are likely to develop disease in the liver. And years ago, this was incurable, but now I'm being very upbeat here because I have seen this firsthand in the US, in Dublin and here. Surgeons can remove disease from the liver with very, very realistic possibility of long-term survival. And why does disease go to the liver? Well, it's because the plumbing arrangement in our body, the vasculature, drains the bowel, the blood vessels, the venous blood vessels, and the first place that these blood vessels go to is the liver. So the liver is a sieve to filter out waste products and to make energy from foods that we take in. So it's obvious if there's something in the bowel, it will go there first. So this is the complexity of bowel cancer now. This is just for illustrative purposes, very complex diagrams on how we give treatments, the sequence, survivals have improved, and chemotherapy got a very, very bad press in the 60s, 70s, even 80s with toxicity and quality of life. And now I really try to reassure patients that, of course, there's nothing easy about chemotherapy, but chemotherapy can be tolerable and you can, in many cases, get on with your life, acknowledging it's not easy, but it's way better in terms of side effects where we gave pretty horrific things back in the 60s, 70s when there was a big learning curve. So bowel cancer that isn't even operable can do much better now with chemotherapy, biologic therapy, converting disease. Here's if you have no liver surgery, and here's if you have liver surgery, you can see the difference in survival can go years sometimes. So the difficulty I face with in my professional life every day, one of the many difficulties is that bowel cancer, colon cancer, just the same as any other cancers, it isn't one disease. So bowel cancer is many diseases, and it's many diseases because of things like this. There are many different subtypes, genetic subtypes, and under the microscope, these cancers look the same when they're removed by the pathologist. But when you delve in genetically, I'm not a geneticist or a scientist, and I sometimes struggle to understand the meaning of all of this, but some of these genes are really important in cancer. I draw the analogy to a train. So the driver of the train is the most important person probably on the train because he or she drives the train. Some of these genetic mutations are drivers. They drive the disease forward in a bad way. Some of them are passengers, like the way we're passengers on a train. They really don't mean much in terms of the journey from Cork to Houston, for example. But some are really important. So scientists make great inroads discovering driver mutations and passenger mutations. And we've discovered a whole array of genetic changes in colon cancer. And we now subdivide them into different types. And there's even further extrapolation on this. And for illustrative purposes, colon cancer was treat, no surgery if it's advanced, and then life expectancy is limited. Now we have this like a subway map. You can go down multiple different routes with surgery, radiation, chemotherapy, immunotherapy, biologic therapy, personalized therapy, genetic testing. While I'm on the concept of genetic testing, websites look very good for genetic testing. You can get your tumor tested for lots of different genes, but you need to be aware of this because the majority of genetic changes in bowel cancer are passenger changes. And unfortunately, a lot of genetic testing that's very, very high tech costs money. Patients have asked me about this. Patients have paid sometimes €1,000, €1,500 to get this done. And I try to give realistic expectations, like here, less than 3% of patients are likely to have any real benefit from genetic testing. So I'm not discouraging genetic testing of tumors. This is nothing to do with family history, but I just think the expectations need to be a little realistic. Another point I wanted to mention is different locations of bowel cancer. So we all started off as an embryo, and the embryo is divided into three: the foregut, the midgut, the hindgut, with respect to the gastrointestinal system. And the right colon has a different embryologic origin to the left colon. So therefore, right-sided colon cancers are different to left-sided colon cancers. And remarkably, there seems to be very little colon cancers in the middle. and we don't know why this is. But this has got to do with embryologic development. Where the disease is can be a surrogate of how your genetics are, of how you will do, of why you got the cancer. And this was staring people like me and scientists, brighter people than me for years in the face, and nobody copped it until recently. So there's a distinct difference between right and left-sided bowel cancer. And that's really important for oncologists like me to know, and for patients and their families to know as well. So bowel cancer differs by location, by gender, by molecular, and so on. And as an overall picture, although this is not absolute gospel fact, left-sided cancers appear to have a bit of a better prognosis than right-sided cancers, although thankfully I have many patients who would debunk that. This is a heterogeneous population. So can we use biology to determine our treatment? We can. I'm not going to get into all the genetics, but different genetic changes, the side of the cancer, the different subtypes, lots of different things can dictate management and have implication on management of cancer. And as a final treatment discussion, I'm sure many of you have read about immunotherapy. So our immune system, which we all have, can deal with foreign objects in our body, like infections, COVID, the flu, cancer. So in some patients, the cancer can be very slow growing. And maybe that's because their immune system is so good, it can control it in and of itself. I have many patients like this. So the immune system now has been studied in great detail as being a potential treatment for cancer. And the word potential now is probably incorrect to say, because it's very real. It's all here. So we have immune cells called T cells in our bloodstream. These interact with tumor cells and they try to kill tumor cells. But often, unfortunately, there's too many tumor cells and your immune system can't deal with it. So these drugs called immunotherapy can stimulate the immune system to hit cancer cells. And it appears that tumors that have a lot of mutations, like certain types of bowel cancer called mismatch repair deficient bowel cancer, which is approximately 5, maybe 8% of bowel cancers, these are exquisitely sensitive to immunotherapy. So sensitive, in fact, that the results are really spectacular. So this is a drug called pembrolizumab. I don't really put up trade names and talks, but just for many of you have heard of this drug, Keytruda. So this drug has changed the landscape in many cancers, including a small percentage of bowel cancer. Unfortunately, it's a small percent. I don't know why that is, but it has changed it. And there are big scientific papers, big papers in the world that have changed the landscape in a small percentage with these drugs. So you can see here, here's a tumor in the bowel. After 6 months of immunotherapy, it's gone away in those patients that have immunotherapy sensitive disease. And there are big investigators in the United States that led this forward. A lady called Andrea Sursek, who I worked with, has been one of the leaders in this. So immunotherapy is not for everyone, but this is how cancer has changed now. There are a small percentage of patients that benefit massively from medication, from drugs, rather than everybody benefiting minimally. So to finish up, early detection leads to better outcomes. Please pay attention to the screening. I've talked to some patients and the screening kit was lying in a fruit bowl on the kitchen table for 6 months before they acted on it. And then there's all the retrospective questions. I should have done this when they came in. So thankfully that's not common. And we really try to educate patients that screening works. Please do the screening. And I hope we do screening at a younger age. Lifestyle modification is very important. Another talk in and of itself, exercise, diet, and maybe aspirin. Taking aspirin might be a good thing for bowel cancer as well, for survivorship. I can talk about that later. Treatments are better. They're much better. I'm here 13 years and you wouldn't believe the difference in the treatments. Most bowel cancers are at an early stage because of the screening and because patients, the public, are much more educated than were years ago and go to doctors earlier. And advanced bowel cancer can be a chronic disease like diabetes, like Parkinson's. You can live with it for years. It doesn't mean it's terminal in a significant percentage of patients. And probably a big take-home message is the multidisciplinary involvement. No one doctor, no one nurse is an expert on bowel cancer. It's a multidisciplinary involvement, and that's super, super important. Thanks for your attention.
Are you happy with that? I think we'll wait to the end to take questions, if that's okay. I think next up we were going to hear, most importantly, and I think I'm really looking forward to hearing from our patients. We have Clodagh and Brendan. I just want to reflect for a little minute because you know, Derek gave a wonderful talk and an overview there, and I should have said this at the start. I think we all need to be conscious of each other's journeys here. It's easy for me, I guess, but I recognize that many of you here are patients. Some of your loved ones may have passed, and some of this may be very difficult. So and as we talk through some of these treatment options, I know you're looking at names of drugs and saying, oh, I had that. So, you know, sometimes as oncologists, we forget some of the emotion that this can generate. So very safe space here today. And I'm sure some of these stories will be emotional and very open for everyone to have a conversation at the end. So, they're very busy chatting. Clodagh. Clodagh with no voice. Clodagh and Brendan, I think we're going to sit here. Do we have
We have a rolling microphone.
Do we have a rolling microphone?
We're the first life could be that glad.
Okay, so they'll turn on, Scott's just going to turn those on.
Thanks, Scott. Yeah, so we have two patients today, and actually one of the most powerful and positive things about today is the connections that everybody is making, and we can already see that from some of the patients here today. But this is Brendan, who I've not met, and now I've got a new friend, Brendan Donnelly, and this is Clodagh Dining. So we are going to spend the next 20 minutes hearing a little bit about their journeys and a little bit on the patient experience, what the positives and maybe what some of the challenges have been. So Brendan, I'm going to hand over to you and perhaps take us through a little bit about your story, where you're at, and then we can go from there.
Thank you very much, Monia. So I'm here for balance on lots of points. I am the token fella. With all the strong, capable, and open, empathetic women who tend to lead these conversations. I am the all those things, but also now. I am also a left-sided cancer. So that's probably why I'm here. 5 years clear this May. And I was stage 3. I was also one lymph node into the category that got me 12 months instead of 6 months, which again probably helped as well. And my journey was, you know, it's funny when you're going through this. I know a lot of you will be in this boat. You will feel, oh, woe is me, oh, the luck, oh, the heavens, oh, the fates of the gods. And the last 5 years has taught me, in so many instances, I was unbelievably lucky in terms of the breaks I got that got me to be sitting in front of you. First of all, I had really subtle symptoms leading up to the point where I was diagnosed. I've had an emotional stomach all my life, right? So if I was stressed, if I was busy, if I was, you know, if I had deadlines in work, then my bowels didn't work the way they were supposed to at the best of times anyway. So I tended to give them a long leash and then I to just say, look, you do what you do, and we'll just keep on going unless things get bad. And it never got bad enough where I was really worried about it. And then in the spring of 2018, I was 48 years old. I was very busy in work. I'm self-employed. I'm a communications consultant. And I was getting a little tired, and I was trying for the nth time to do a couch 5K. I was getting slower and quicker. And I had pains in my back. I was getting physio treatment for what I thought was a pulled muscle. And then over the course of a couple of just days, I suddenly began to get much more alarming symptoms. I would get these spasms of pain, and my bowel output was suddenly getting thinner. Now this, we all know in this room, instant red flag, instant, you know, oh God, you know, run for the hills. At the time, and it would still happen, if I'm under stress and if I'm busy, frequently my whole body just shrinks. It kind of goes, you know, and so therefore I wasn't that surprised. But it just didn't stop getting thinner over the course of 2 or 3 days. And then on around lunchtime on the day before I was diagnosed, I sort of felt this kind of total closure. And I realized that's odd. And nothing was happening, absolutely nothing. I couldn't even fart. And that was probably what saved me, because I had as the resident who diagnosed me in the hospital in the A&E, said your growth moved sideways across your bowel and sealed it shut very neatly, very quickly. So it didn't go up, it didn't go down, it grew across. And so I had a complete total seal bowel. And so I had this really, it's a great word, exquisite. I had an exquisite pain, which is a lovely word. And so I sort of, because I'm a fella, kind of lived with the exquisite pain for an afternoon and a night. And then finally my wife said, go do something about this, don't just sit there and wait for it to change. So we were going to go to the GP, and then so I said to her, I'll get up at the rest to go to the GP, I'll be fine. And she drove to work thinking that he doesn't look well. So he turned around, came back and brought to A&E. And our nearest A&E was being in hospital, just by geography. We had the insurance to get in and open the door and get seen. It was the bank holiday Friday, and the colorectal surgeon who was on duty at the time, Mr. Ahmed Mashoud, doesn't play golf, so he was there. And so I was seen by a registrar, and then by an A&E consultant, and then by Mr. Ahmed, and they all sat there in a circle. They had brief debates on whether they could relieve the pressure and then work on what to do. And Mr. Ahmed was like, no, we just take it in, cut it out, now, do it. So I was brought in that night, and he cut out a foot of my colon and said to me the next day, it's gone. We joined it back together, again, incredibly lucky, didn't need a colostomy. But they said, given what we saw, be prepared for bad news. And I was like, had the growth scrolled something on the walls, of the colon saying I am bad. And said, no, we know what a good growth looks like, and this is not a good growth. And so by the end of my week in hospital, they diagnosed me with stage 3, 4 lymph nodes. At the time, I didn't appreciate what that 4th lymph node was giving to me. I remember when I eventually got to see my oncologist, Ray McDermott, and I'm a communications consultant. I tend to be dropped into clients and have to learn about stuff and then tell people what I've learned in an accessible way. So I've been researching cancer, researching treatments, and I've read about that, some patients only get to have 3 months worth of chemo. I was like, oh, excellent, that'll be me. And I said, I think I qualify, I'm relatively young, I'm relatively healthy. Yeah, sorry, I do apologize to all the medical experts in the room, I said it nicely. And I think each of my sessions with Ray could be measured in seconds, not minutes, because I was a very straightforward patient, right?
I'm laughing because Ray is probably so sarcastic with the phone.
Oh, Ray, I know, get Ray.
We get him too.
I didn't get Ray at the time, but I love him now. Yeah, I sent him Christmas cards, he sends me cards, it's so good. But he said, he looked at me and blinked.
Derek,
Oh, I know.
There's a lot of pressure. In 2 weeks' time, I don't have anything there.
He looked at me, blinked twice, and said, "Are you a numbers guy?" I said, "Well, no, actually, I'm a colors guy." Because I went to art college, and I was a designer, and I'm now a communication consultant, so I don't think in numbers really. He said, "But do you understand basic numbers and odds?" And I said, "Yeah, basic, yeah." He said, "Right, well, if you put up with 12 months instead of 6 months, it's going to double your chances of getting to 5 years." I was like, arse, okay. And I had chosen to be very open on social media, partly to convince my clients that I was still alive and that I was doing okay, even though I wasn't working. And one of the people who'd been diagnosed the same week as me, halfway across the country, but has a job in Sligo, she reached out to me because we had the same kind of cat. And we had the same kind of cancer, and she had 3 lymph nodes, so she got half the chemo dose. She was slagging me for all the time that I was still getting it. And she then spread to her liver, spread to her bones, spread to lots of places. She's still alive, she's very well. So again, that 4th lymph node made a huge difference in terms of the outcome for me and in terms of treatment. And I'm now nearly 5 years clear. I still am screened frequently. Screening is amazing. Screening is the cure for cancer. We always had and never knew we had it. It is phenomenal. So the only thing is my screening probably will never stop, because every single time I'm screened, they find something. And they find 1 polyp or 2 polyps, 3 polyps, 1 bonus session. And 1 or 2 of the polyps each time is what they call borderline. So I just had a session recently with my team, and they said, yeah. So we found 1, and once again, it's sort of on the edge. It's still fine, it's still benign, but we had to send it to 2 labs and work out, was it actually fine? So they said, for that reason, we're going to test you every year. And again, I think to me, that's an absolute wonderful thing, because, we will talk about scan anxiety here and worrying about scans. When you don't have a scan due, it's just as worrying. So when you're months away from your scheduled scan and you get a symptom. Suddenly we're bonding over us walking to A&E when we were just consummated. I mean, demand MRIs, you know. So there's a real privilege in knowing every 12 months I'm going to get a scope, I'm going to get an MRI, I'm going to get blood tests, and they're going to say, go ahead for another year. So again, that's my story, just to let you know that, you know, not only can stage 4 be a survivable chronic diagnosis, but stage 3 is incredibly, eminently treatable. And we need to get the word out as a group about how early screening is the cure for this, because every single polyp they find is a cancer prevented, and the polyps are very easy to find now. So even if you're not 60 and you don't have it on your windowsill, if you have the resources, you need to go out and talk to your GP and get a fit test every year from age 45 up. We've all put in our recommendations to the Screening Council to say lower to 50 this year. Hopefully they listen to us. But to be honest, you need to tell your friends, your neighbors, your family, if you're 45 and older, get a fit test every year, pay for it privately, get it done. And if you have any symptoms, go to your GP and talk to them about it. Because this is a really rare thing, and it's a very preventable, very treatable cancer. Thank you.
Questions. A couple of things to touch on. You mentioned left-sided colon cancers. So, you know, it's important for some reason, and it's kind of be unexplained, that those under the age of 50 seem to have this tendency to occur in the left. And again, we don't know why that is, but it's just something important that you brought up. Can I ask you, you know, as a survivor of colon cancer, having gone through all the chemotherapy, do you have residual side effects from the treatment?
Yes, I got a fair bit of neuropathy. We now know the benefits of ice bathing and stuff, but it wasn't, you know, a mere 5 years ago, it wasn't common. So I've got a fair bit of neuropathy, and combined with the family history of arthritis, I'm getting nice claw hands, which is great. But it's fine. I'll take that. I can cope with it. I occasionally have to open my phone by nose in winter, but it's something I'll do.
I'm sure there'll be a few who can relate to that. And can I just say, the scan anxiety word is crept in social media. Can I also tell you there's physician anxiety as well? Because these CT scans results do come to us, and I know you're not thinking of your physician. However, we do read those scans with, you know, praying and hoping that those scans are going to be clear as well. So it is that kind of two-way journey, but absolutely, you know, it's so in Canada, all patients had access to their scans in real time, even before the physician seen them. So, you know, it's something that will definitely come in Ireland. We're a while away from it, but just something to think about. Can you imagine on a weekend potentially getting scan results and opening that email on your phone and potentially looking at those results? So it's a whole new world out there with technology, but that's what's happening around the world. And I do think it'll come in Ireland, hopefully soon. So I'm going to come back to you, Brendan, just because I know that I've talked too much and then we'll go over time. And we're going to come to the lovely Clodagh, who many have seen on Ireland AM last week, wasn't it? Last week. Okay, so Clodagh, do you want to take us through your story again? It's a little bit different maybe from where Brendan's sitting, but it's good to maybe contrast the two stories.
Well, when we were talking, I thought, when I heard that yours was on the left, I thought we should swap sides because mine is on the right. So for a couple of years, like for about 10 years, I was having very weird symptoms. When I was planning my wedding, I got this really weird outbreak of herpestic ulcers in the front of my mouth and in the inside. I get these flash rashes. And I even ended up in James's skin or STD clinic, and the consultant there was like, you know, you can't have herpes on your skin. That's like for really sick cancer patients. And it cleared up, and then I couldn't fight infections, get loads of allergies and things like that. And suddenly, this IBS that I'd always lived with really disimproved. I asked my GP for a colonoscopy, and she said, "What are your symptoms?" I had changes in shape of stools. They were very dark in colour. I had been diagnosed with anemia. I had fatigue, obviously. And she just said, if it's not blood wrapped around your stool, you've nothing to worry about, you're too young. And the weight lifted off my shoulders. I was like, woohoo, I'm all right. And off I went, and 6 months later, I was in A&E with a ruptured appendix. And I remember meeting the consultant, Ashfal Mughal, and he brought in this other guy, and he said, this guy's my boss. And I verbally said, ooh, then in my head I went, oh shit, you know, and he turned around to me and I looked at him and it was the look in his eye. I went, oh my God, I've cancer and I'm dying. And he looked at me and he turned away and he said, it's your appendix. And I went, woohoo, again. Excuse me. And I literally said to them, I thought you were going to say I've got cancer and I'm going to die. And the two of them looked at each other. 2 weeks later, I was back in. And more antibiotics. Rushed in for a colonoscopy. Already drip fed very skillfully to the idea that I had cancer. It was my greatest fear in life. And they kind of knew that. So they drip fed it. So by the time they said, look, you're already scheduled for surgery. We think it is. I was perfectly fine. And they said the tumor was tiny. I was 0 stages. I would just need surgery again. Woohoo. And then it was like, oh, it's denser. It's broken through the bowel. It's in your lymph nodes. 1 lymph node, 2 lymph nodes had microscopic cancer. So I was only early stage 3 diagnosis. Again, woohoo, you know, I was going to beat this. And I was scheduled for 6 months chemo. During the time that I was waiting to heal from surgery, I blew up like a pregnant woman and I couldn't breathe. I couldn't even get through the x-ray, you know, just, you know, and my story is very similar to Mary Barnes's. And Professor Gallagher, my consultant oncologist, was on that weekend and he came in and he said, I remember hearing him coming in through the curtains saying to the reg, are you ready for this? And he came through I knew, came through my curtains. And I went, and he said, I'm sorry, it's not good news. It spread to my liver, my ovary, and my peritoneum. I was incurable. But then he said, look, you're young. There are new drugs coming down the line to prolong life. I went, prolong life. And he said, yeah. And I said, look, quality of life is number 1. And that's where we've been working for ever since. In that time, I was put on a punishing dose, but the position of my ovarian cyst and the size of it impacted on my entire esophagus. So I had chronic anorexia, chronic vomiting, which damaged my voice. I used to be an actress and a singer, so, and a teacher, so, you know, of all things, but look, I'm here. So after the 4th cycle, it was successful. We changed to maintenance, blew up again, rushed in for surgery. They took it out. My cyst was the size of a newborn baby in weight and size. It was that size. And they said when they took it out, all my stats came back to normal. So he sat down. Professor John Larkin was my surgeon with Professor Paddy Moriarty and James's. He sat down and he said, Clodagh, we took out 90% of your cancer. We believe. I was put back on maintenance. And that maintenance liquefied the tumor in my liver, which is a brilliant result. And it's remained stable since then. Since then, the peritoneum has kicked off. So I have tiny activity in my peritoneum to such an extent that I made the radiology meeting where some doctors were saying she's no growth and others were saying, yes, there is. So as a precaution, I've now been moved to targeted therapy called Sturvaga. So same as you. And I've just finished my 1st cycle of that. But we know that that penetrates the peritoneum more successfully. So there we are.
Thank you for that, Clodagh. So you've been through a lot, clearly, and you know it is life altering when you lose, especially your identity as an actress and your singing abilities. If you were to name some positives for the journey so far, before we go on to some of the challenges, because I know there have been a lot, but and we'll ask Brendan as well, but kind of positives of the healthcare system thus far, and then things that you might want to change.
I have to say, I feel incredibly lucky, just like you. I know they laugh at me in James's hospital. You know, no, you're not lucky, Clodagh, you know, but I do. I feel incredibly lucky. I was measured for a stoma when I had that surgery for the cyst. But I was also told that there was a high chance that they would not be able to remove it, which meant goodbye. I was incredibly lucky. Not only were they able to remove it, but they were able, I have no stoma. Not only that, but by the time I got to surgery, my cyst was bleeding. So I became an emergency. So I frightened the bejesus out of my 2 consultant surgeons to the point where he was practically shaking, going, "You're so lucky, you know, we got to you when we did." So I do feel incredibly lucky to be here. I feel incredibly lucky that my thighs are ruined from a Pilates class I did 2 days ago, you know, and I actually went out jogging that day as well. You know what I mean? So like, I feel incredibly lucky to be part of this group, to be here, to be with Marie Keating, to have our own group, the Irish Colorectal Cancer Society, and to hear other people's stories, and to be maybe at the beginning of a cusp of a wave of a movement to highlight to the government that we need investment, we need more money and more focus to stop this curve. We all know that word now, to flatten the curve of this rising of early onset colorectal cancer, because it not only has an effect on our healthcare system, on our financial state, it costs the state a fortune. You know, not only that, but you know, a lot of us have young families. I do. I'm not working. I cost there. I cost the exchequer. And also, it's so easy to fix. And it's so easy to stop. I'm baffled by Deborah James's work in the United Kingdom that it's still happening there. 20-year-olds have my diagnosis, have beaten a path to their GPs, because their GP is not a GP fashion session.
No.
It's the guidelines they're following,
Yes.
that they've been trained to follow. My GP, my former GP, because I moved, she said, "I'm horizontal on the floor with shock." You know, this has a psychological effect in our medical profession as well. And not only that, but on our fertility, which isn't addressed either, you know, and it's rising. So we need to chain ourselves to Simon, what's his name? I nearly called him Simon Coveney. I went to school with Simon Coveney. So that might be something. Simon Donnelly, Stephen Donnelly, you know, but that's the one.
I know, and your words are really powerful, and you brought up a lot of things there, Clodagh, in terms of, you know, psychological impact, fertility impact, and we're going to hear from some of our other researchers and medics a little bit about their experiences and their research, but it's really important. But I think you also touched on something really important. There is an awareness, but that needs to happen in order to flatten that curve. But you guys have already started that awareness today. And I think it will continue now, because globally, this isn't an Irish problem, this isn't just a European problem, this is a global problem where the awareness of under 50s, and actually the proportion of patients that's increasing mostly is that of age 20 to 39. So even under 40 is where we're seeing most increases in colon cancer, as in the numbers per year are going up.
I think the other really important stat on that is that below screening age, I think the statistic is over 60% of those patients will be stage 3 or 4. You know, so when you look at their statistics earlier, obviously a lot of stage 1, the screening process, but they're not early on.
70%.
70%. 67%.
Yeah. So those that are younger definitely have a later presentation, and again, that's multifactorial, and we don't understand all of it, but absolutely, you're absolutely right. Sorry, I'm going to let Brendan speak, and also maybe a couple of other comments, and if anybody else wants to identify and give their story, now is a good opportunity to do so.
I'm just going to reflect the kinetic signals from across the room saying, end this section now.
No. This is the most important section. No, we're not ending, sorry.
Yeah, no, but again, the only point I was going to say was that the most useful thing that I got once you're a patient was, and again, I don't know if this was a big thing, I hope it's in every hospital, was I had somebody I could call when I felt overwhelmed by my treatment to help me manage the symptoms so that I finished the treatment. Because too many people feel, I can't do this is going to be too hard, I'm going to feel too sick, I need to stop. And 99 symptoms out of 100, there's some other drug they can give you, or some other infusion they can give you to get you through, to get to the next one and keep going.
Especially with oxalic platinum.
Yeah, especially, yeah.
I have to say, I did icing for oxalic platinum. I was the first patient in James's. The first time I went in for the infusion, they didn't know about it, the nurses. But the next 2 weeks I went back in with my ice bag and the whole lot. The oncologist was like, oh yeah, go ahead. All the nurses knew about it, but I've never been circled so closely in my life during an oxalic platinum. How are you doing there, Claude? Oh, even the
Breathing your toes.
yeah, just because they were so scared that something would happen. Because I had a bunch of ice in my mouth, and a whole lot, but it does work.
Yeah.
So Colon Town is where we got the information. Jane gave me the information, so maybe you'll give it to me again because I lost it. But it does work.
So we might hear, and that's thanks a million, Brendan and Toda. We might hear from a couple other people in the audience if they want to share some experiences.
Hi, I'm Ashley, I'm a patient of the wonderful Prof. Powers there, Derek. And thanks for your stories. The saddest thing there is I think said she was a singer. I'm so sorry. But yeah, you touched on a few things I wanted to ask at some point. You said it's not a GP bashing event, but this is the choir, so and the GPs really are the problem. Like, how do we get it down to them? Because one, we're too young, and second, a lot of us have the double whammy of being a woman, and even the best of GPs are still, disregarding a lot of our issues. I presented for 11 months with pain and many of the listed symptoms, and I did have a colonoscopy, nothing was seen. I couldn't have done any more. And I was told it was IBS. I had to go back and fight for more scans. So that's one thing. But also you mentioned fertility. So we really, the medical profession really have to come to terms that they're dealing with women now who haven't maybe yet had their family like myself, and fertility really has to be considered around these drugs. I feel like the nurses in particular treat us all the same, like they treat me like an 8-year-old patient. There's no nuance, there's no individualism. And we mentioned neuropathy, and I'm absolutely terrified of that. I'm not trying to honestly icing with Prof. Power. And I just feel like I've lost a lot of my identity through this as well. Like I would have trained 6 to 7 days as a very active amateur triathlete, weight, Pilates. It's a huge part of my identity, and the thought's not really my feet, and being able to go back to that is
It'll come back. Yeah, it'll come back.
Good grippy socks for Pilates.
Yeah, exactly. It's still doable.
Yeah,
It's different.
So there's just a lot that's not considered, I think, with us younger and female patients. Yeah.
Can I ask you, Ronnie, as well?
Yes.
Prof. Gallagher said that in James's hospital they were going to open a young cancer.
So we're going to come to that, and thank you for bringing that up, Rhoda. And actually, so this really important thing she brought up. So awareness and community awareness, GP awareness, fertility, and how we manage younger people that might have different needs compared to the 80-year-old, for example, who may have different needs. And we're going to bring all these together at the end, if that's okay. Is there anybody else who would like to give their story or mention anything? Yes, and those questions are a nice segue into Mary and Megan.
Thanks very much, Ronnie. I'm debating whether I should have put my hand up.
No, you should. Well, that's the gut feeling is then you should.
And I'm going to join Brendan as another token man in here. My name is Gerard. I live here in Cork. I once upon a time, a long time ago, I trained as a general nurse in CRH, as opposed to the CUH now. And so I'll make a long story boring and shorten it if I can. I have been a patient of Derek's. And last week, 6 years ago, I finished my chemo. I'm a slightly different story to maybe the other two stories as well. I'm rectal cancer. And I suppose because I'm a nurse and I work I work in the pharma industry actually, but that's neither here nor there. But actually, because of my nursing background, my symptoms were very nondescript. There was no weight loss. There was no real blood as such. There was no dark stool. There was no bright red. But the one thing that did catch my attention was the feeling of fullness and bloating after eating just a small little bit. My wife is also a nurse, we're classmates, and she said, you need to take yourself off to your GP. And I'm going to kind of give a positive spin with the GP actually. And I was 49 in September 2016. And he said, what age are you, what are the symptoms, etc. Blah, blah, blah. Have you ever had a colonoscopy? I said, no. He said, well, you need to have one. Where do you want to go? And I kind of went, interesting question, where do I want to go? And I suppose it's because I had some level of knowledge within the medical community. And I went to Professor Micheál Riordan. I got access through the matter private, Brendan, just like you, the Beacon. I had insurance. I was able to get in. I got in August 2016. I had a scope, and I knew when he came out, he said, yeah, I found a couple of polyps and I will come back to me in the form. And I met him, and I was the last, just a couple of things. I was the last patient on the list below in the matter private, had to stay on a Tuesday evening. And yeah, to be fair to him, because I knew him of old, you know, I had an adenocarcinoma. It was poorly differentiated. It doesn't look good. And this was the 20-something of August. And the 15th of September, I was on the table in nursing. So I had a TME, total mesorectal excision. I had a low anterior resection. I had a whole big whack taken out. I had 12 positive nodes. My sins out of about 30 odd that were taken. So I was straight away, I had a stoma, I had an ileostomy for my sins, and I didn't have radiation, and it's always very intriguing. I know the MDT was probably very interesting because at the time, given everything that was said by Grainne and Derek, and I know Dr. Kelly is here as well, ordinarily it would be radiation first, shrink it, and then, but in actual fact, to Micheál, he said, it would be very difficult for me to operate on an irradiated valve, and it's too low down. You need a little bit of a stump for the anastomosis, you'll have an ileostomy, etc., 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 all those. I actually would finish by just saying that the most difficult thing for me, the oxaliplatin brings it all back. The neuropathy was for 3.5 years nearly. But we had a drug that I took that kind of helped somewhat. But the stone was actually one of the most difficult things I did, to be honest with you. When I had it reversed in May of 2017, a fortnight after being reversed, I was nearly saying to my wife, I want to go back in and have the stone back. Because it took the whole of the rest of the 2017 for it to actually get back to normal. The new normal. Sorry, I know what.
It's really nice to have the courage to do so. I'm glad you put up your hand. Really important lessons there, and there is always good to give some positive feedback, because this is how we do create awareness amongst our community colleagues as well. And we might hear from a GP a little bit later on. But unless anybody has any,
Just a point to touch on that. Jonathan said there can be like a menopause induced, or didn't mention fertility, but when we said menopause. So I've had surgeries, and from that very first day, my first surgery, immediately in the surgical menopause. And it's actually only got HRT this week. So I've been trying to deal with this for 3 years, and then I've eventually decided I'd take it, but that is part of it too. And fertility, I know people are younger. I'm very lucky. You're very lucky we've had babies. People haven't had babies and this happens. So
yeah. Thank you so much. And Mary, that's right. Brilliant. I'm going to try and keep remembering everybody's names, but thank you for that, Mary. You're absolutely right. And putting someone into early menopause when you're young and a female is very, very difficult. And chemotherapy can do that as well. Yeah. And oncologists, maybe not the best people listening to some of those stories and complaints, and if I will be honest.
Can I add to that? Anyone who's in the Wicklow, Dublin and Kildare area, I know that much, are entitled to free, if you have a complex case, i.e. cancer, you're entitled to with Dr. Deirdre Lundia. And it's an amazing service. And even if your cancer is estrogen fed, there are alternatives. And for any men who are here who have prostate cancer, I know too, you know, if you're on the testosterone blockers, take the antidepressants. They're not for your depression, they're to manage your symptoms. You'll stay on that treatment longer, because a lot of people stop that treatment, the hormone blocking treatment, because it's so tough. Surgical menopause, it's the same thing, it's really tough. you know, so take the alternatives. And there should be one for Cork people as well. I just don't know what it is. Or who it's run by.
And it just, one of the things from today is to hear kind of the positives and to take those back. There shouldn't be any disparities in Ireland, no matter where you live, in terms of access to care. That's one thing that a lot of us are very passionate about. So digital lovely service is fantastic. But yeah, thank you for bringing that up. So we'll address some of these at the end, but this is a fantastic segue into some of our next talks. But a big round of applause for Brendan and Patricia. Okay, so next we have two, it's very medical oncology heavy, just like some biases here, but we're going to have Mary O'Reilly speaking. Mary is one of our senior specialist trainees in medical oncology who's working with Ray McDermott. I see there's a lot of Ray McDermott patients here today. And she's going to talk to us about some of her research. She's doing a PhD, which is fantastic. It's really important research in Ireland. It's a huge interest of mine, and it must be emphasised that we need to invest in research in Ireland. So it's fantastic to have Mary doing a PhD in young onset colorectal cancer. So we're going to hear from her and then from Megan thereafter, and we'll certainly address some of the questions that have been raised in that patient session. So welcome, Mary.
Thanks very much for that. So yeah, my name is Mary O'Reilly. I'm delighted to be here today. I'm a proud member of the Irish colorectal cancer community for the last number of months, and Deputy Marie Keating Foundation have done a great job today. So I'm delighted to be here. I think my talk fits in quite well here. We've just heard from Claude and Brendan and a number of other patients about how their journey has been to here, and my research on early onset colorectal cancer hopefully will provide some hope to a lot of the patients here. And I suppose I'm going to talk a little bit about research that's being done in Ireland, and I'll just briefly touch on some international research also. So a little bit about myself. Probably the most important thing about me is I'm from Cork. I'm currently training to become a consultant medical oncologist, and I want to specialise in treating early onset colorectal cancer. His ears must be burning today, but I first, I suppose, found this passion when I was working with Professor McDermott in Vincent's hospital in 2019. We saw that, like internationally, the rates of colorectal cancer in Ireland were increasing. We could see a lot of patients were presenting to the clinic with early onset colorectal cancer. We looked at the differences between those who had early onset colorectal cancer and later onset colorectal cancer, and we saw that there was significant differences there. So when an opportunity arose to commence a PhD in Systems Biology Ireland in early onset colorectal cancer, I jumped at it with both hands. And currently I spend 3 days a week in the laboratory up in UCD, and I'm 2 days a week still working in clinics in St. Vincent's Hospital. So the title of my PhD is Multi-omic Profiling of Early Onset Colorectal Cancer. This is quite wordy, and I want to break down exactly what it means. So multi-omic profiling is a method of analysing and integrating information derived from cells in order to understand how the cells function. In other words, how different members of a team work independently, but also how they work together as that team. We know that our cells have strict procedures that must be followed out in order to maintain structure and function and status quo within a cell. So the different team members that I'm looking at, first of all, there's genomics. This is the study of DNA. This is the manual for the cell, which contains the instructions on how to behave. The second team member is transcriptomics. This is looking at the RNA in the cell. This is the step where the manual is read and the instructions are carried out. And then the third team player is proteomics. This is the study of protein in our cells, which is the final product when the RNA has read the DNA. So I compare that cake, and genomics is the recipe, transcriptomics is how the cake is made, and proteomics is the end product of the cake. And then multi-omic profiling is looking at this as a whole, so the different steps together. So my PhD, as we've already discussed, the issue and why I'm carrying out this PhD is because we know that early onset colorectal cancer is becoming increasingly prevalent, and we don't understand why. I am trying to deeply analyse these colorectal cancer tissues that we're getting from patients in St. Vincent's University Hospital, and we're using multi-omics techniques, as I just described, to compare healthy cancerous tissue in young patients compared to older patients. And then I'm trying to figure out which of these team players is the most useful to provide us for information to improve outcomes for patients, and then to investigate if this technique can be integrated into our clinical practice. And we believe that this research will lead to the development and introduction of different techniques that we will use in the clinical setting, and ultimately improve outcomes for patients with early onset colorectal cancer. So this is just another schema really showing exactly what we're looking at, with the final aim to have a better understanding of why early onset colorectal cancer happens and to help us improve outcomes. So we've already touched on this, but I suppose the take-home point that we all agree on is that we all need to be more aware of this disease, both in the general and medical communities. It exists, and its incidence is increasing. I really just put up this slide which highlights a number of points that have already been made today. So these are the Irish GP referral guidelines that direct GPs regarding patient symptoms of who should be sent for endoscopy. We can see here that especially in the younger age cohort, there's really specific symptoms that need to be made for GPs are recommended to refer patients for endoscopy. Now, a number of patients in the early onset colorectal cancer group, the Irish colorectal cancer community, sat together and said, this is really strange. We have had symptoms that wouldn't recommend that we were referred to endoscopy. I wonder if there's other patients who are in the same situation. So the patients of the Irish colorectal cancer community, Niamh Conroy, Patricia Stack, Mary Barnes, Clodagh Downing, Deirdre Fleming and Jane McCoy all set out and developed a patient survey, which really, from going through the literature, there isn't anything like this that has been published. There's nothing out there of patients saying, you know what, the system that we're in, it isn't good enough. How do we get information to so that we can change, really? And it's a really amazing survey that they've carried out. These are really just early, a snapshot of early results. There was only 24 patients who had answered at the time that I went through this analysis, but really it shows a really strong trend. So we can see that almost 1/5 of patients had symptoms for over a year before they were diagnosed, and more than 50% of patients had symptoms between 6 and 12 months. 1/3 of patients felt they were not referred for investigation in a timely manner. And the bar chart on the right really is just to demonstrate that people present with a large variety of symptoms, and many of these are not included in the referral guidelines that GPs have to help guide them. So where do we go from here? Myself and Grainne are delighted to be involved with the Irish colorectal cancer community, and we're helping to develop and expand this survey nationally with the Irish colorectal cancer community to help guide and shape policy. And also we're working on establishing an early onset colorectal cancer registry to help with our research. So just to finish, we've talked about the increasing incidence of early onset colorectal cancer, and there's been a wide array of research being done here. But one study that I thought was quite interesting that was published in Science, called A Common Cancer at an Uncommon Age, it just really talks through, the authors talk through what they believe are critical areas that need investigation. In the middle of the slide, we can see what they think are the necessary scientific research that needs to be done. And all of this is happening in Ireland at the moment. They had a number of recommendations, which I thought were quite interesting. Firstly, the development of specialised centres of excellence. And I know Megan's going to talk about that. We need more studies, which we're trying to do in Ireland with early onset colorectal cancer. We need to form global collaborations to facilitate accrual of studies and also to represent minority patient populations. And we also need to talk about screening in younger patients and patients who are of higher risk. So with that, I'd just like to say thank you, especially to the Irish Colorectal Cancer community and the Greally Keating Foundation, and to all my supervisors as well. Thanks all.
We are running a little bit over, so why don't we have another 10 minutes?
5 minutes with 5 minutes with coffee. Sorry, no, everybody's saying coffee. So I just want to say actually a huge congrats to the girls who've organised our patient survey. It is extremely powerful. Patient-led research is really important. It's becoming more common, and we're hoping to take some of this to Cancer Trials Ireland, hopefully to look at evolving this questionnaire that has been devised by the patients. It will be hugely beneficial to hear about the symptoms that young onset colorectal cancer patients in Ireland have had, so we can again inform awareness and put positive spins on this as much as we possibly can. So huge congrats to everybody who's been involved in that, and Mary is doing fantastic research. I firmly believe if there's research being done in centres, it really does bring us all up to speed on what's going on. So thanks, Mary, for all of that work. The other thing that we do want to try to do is create a national registry for patients so that we can begin to understand the epidemiology, because it is epidemiology being kind of, you know, maybe the risk factors, and Derek mentioned this, like, you know, we have very fit people who get colon cancer. There is hypothesized risk factors, but nobody actually really knows exactly why this, you know, is happening in young people particularly. So if we can try to create registries and learn from that over time, I think it would be important. So now I'm going to introduce Megan Greally, who is a consultant medical oncologist specialising in GI medical oncology and breast oncology at Beaumont Hospital. And Megan worked in Memorial Sloan Kettering, the same centre as Derek, obviously an amazing centre in the US, and has some experience with some of the young onset initiatives that have been set up there in specific centres for young onset colorectal cancer. So we'll hear briefly from Megan and then we'll have a break.
Thanks everyone. I won't delay too long and go through the coffee break. Thanks as the other speaker said for the invite today. It's a privilege to be here. So just as we've heard, this is a real growing problem that was really just first recognized as recently as 2015. The States when they saw using kind of SEER data, which is commonly how they look at data, you know, in demographics and epidemiology, as Grainne mentioned, that there was like a doubling of incidence from kind of the last couple of decades, since about 1990, in colon and rectal cancer, and more dramatically actually in people in their 20s and 30s, but also as we've heard, affecting people up to the age of 50. So with this, there is a recognition that because of the epidemiology changing, this becoming a significant public health threat for a younger population of people. And again, as we've heard, there are significant knowledge gaps in young onset colorectal cancer as to why this is happening. So, you know, several centres in the US began to recognise a need for more coordinated, cohesive care for this group of patients. I suppose there has already been a move towards, you know, with the AYA or adolescent and young adult oncology grouping, that services are being directed towards them. But you know, you kind of fall between two stools with the early onset colorectal cancer patients, because it's in that middle age group that we're not, you know, so used to dealing with compared to patients over 50, as we've heard that's, you know, the cohort we would have been used to historically having in our clinics. And so that can be quite isolating for people in their 20s and 30s, that they don't feel they quite fit in. So, you know, two kind of pictures here of the Twitter handles that Memorial Sloan Kettering and Dana-Farber have now, recognizing a need for this more cohesive care. And so if you look across the US, it's Memorial Sloan Kettering was the first centre in 2018 that recognized this need to provide coordinated care to help people really navigate these unique challenges that they have. And then other centres have followed. They are quite concentrated along the east coast of the US, I would say, and having done kind of a search of centres around the world, there isn't anywhere really outside of the US that I could find right now. So Dana-Farber in Boston, MD Anderson in Texas, they have centres in Vanderbilt in Tennessee, Cleveland Clinic, Massachusetts, also in Boston, and Roswell Park in New York State. And outside of that, this hasn't, moved more from those areas as of yet. So Memorial, because it was the first centre to set this up, they have published some early data on their experience. Their objectives really were twofold. One, focusing obviously on the clinical care side of things, to as I say, make this a more coordinated effort and looking at those unique needs and setting in place structures to try and deal with them in a more systematic way. But then also alongside that to investigate why this is happening, and looking at the causes, potential causes, and researching, how we should approach this in this particular group of patients. So in terms of, looking at what needs specifically they needed to address, the Colorectal Cancer Alliance did a survey in the last decade, just prior to them setting up the centre, and they found, several issues that specifically affected patients in this age group. One was that, there were emerging mental health issues, obviously anxiety and depression, and the grief reaction that happens when you're diagnosed with colon or rectal cancer at an early age. Things like, having been in full-time employment, having busy lives, and all of that kind of coming quickly to a halt and managing that. And then, people obviously in this age group have children, and addressing those needs. So there's a whole wide variety of different issues that this group of patients face. So this is their initial schema of what they were trying to do to bring in all the different components of care. They obviously, from the medical side, so colorectal and hepatobiliary surgery would be the main strands from a surgery perspective, obviously, because patients with colon cancer, rectal cancer have a higher propensity of disease spreading to the liver that can potentially be operated on. GI, radiation oncology, and then so both medical and radiation oncology, and focusing on the specific side effects and longer term side effects that patients might deal with related to our systemic treatments and our radiation. And then social work, because as I said, people have issues with young families, dealing with what we call financial toxicity, but what really just means, suddenly being out of full-time employment or education, and the impact of that on people's quality of life. Genetics as to whether, they need a referral to the genetic service if there's a family history, and then the growing, input from psycho-oncology and psychiatry in providing multidisciplinary care. And then on the research side of things, they are inviting all patients now to complete a risk assessment questionnaire just to see if there's any trends in risks that might emerge, as well as medications and antibiotics, taking stool samples, genetic testing, both of your blood to see if there's something in your family history, and then testing the tumor itself as a research tool. So in the publication that they that is there, they talk about a few specific areas they focused on. So they brought in a dedicated social worker to focus on this patient group in particular. We've heard about the fertility concerns, and that Colorectal Cancer Alliance survey also specifically pointed out that at least half of patients had not discussed fertility with their oncologists, and that was obviously, given the differing age range, something that needed to be brought into care in a in a cohesive way as well. Sexual dysfunction is a major issue, and again that there needs to be more specialist care involvement from an earlier stage in diagnosis to deal with this, as well as nutrition, integrative medicine, which is a specific department that they have where things like nutrition, massage, yoga, all of that being brought in from an earlier stage, and as mentioned, psychology and psychiatry and such. So they did a survey of what the patients felt that was positive and what potentially needed improvement. Just to briefly say that in general, the was mostly positive feedback. 70 to 90% of patients generally feeling that that these services were helpful and were at a reasonably useful time point. There were differences across when patients felt that these services should be introduced, because obviously the first day of diagnosis, there's a, it's overwhelming and you're inundated with information. Is that the right time to necessarily bring in all of this information? So, some people found it helpful, there's kind of a disparity. Some people found that first treatment visits or first visits in general were a good time, whereas, many people then felt that actually later on was better. So there's work to do there really to figure out where these things are best utilized. And then this is just an MD Anderson diagram of their approach to this. It's very similar. They do specifically just mention, which I think is important, the osteostoma care, which isn't in the memorial scheme or didn't get a whole lot of attention. They obviously mention fertility and social support as well. And then they specifically mentioned rehabilitation services being, in relation to physical therapy or physiotherapy, and the importance of exercise, because we do know that exercise reduces the risk of colorectal cancer returning, and that we need to be more involved in educating patients about this going forward. So then just very finally to mention that just very recently last month, this was a publication referred to as the Delphi Initiative. So this was 69 experts in colorectal cancer coming together really because the guidelines we have are not age specific, they're related to all patients with colorectal cancer. And to look at, are there specific recommendations that should differ from how we approach the disease in general? Really they made several recommendations, but just I think the ones to highlight are that, that in these patients, blood and stool iron deficiency anemia or any unexplained weight loss should prompt a colonoscopy within 30 days. Patients should have gene testing, as we mentioned, not just genetic testing to determine if you inherited something through family, but testing within the tumor, which helps guide treatments. They didn't find that because you're younger, you should have a more intensive treatment. You shouldn't have more aggressive surgery necessarily or more intensive chemotherapy because you're younger. There is not strong evidence for that at the moment. And then other than that, really the big thing was that patients should have fertility information and referral to reproductive specialists as part of their care. I think as some of the patients alluded to, that they will always be on surveillance going forward, and that's a very important strand within the survivorship aspect of things, that at least colonoscopy at least every 5 years. And then finally, the last line there in supportive care, some younger patients struggle more with nausea. And so they recommended that in general, we should think about giving stronger anti-sickness medications from what we might normally do for our general approach to this, and early access to exercise and nutritional programs, and also as I mentioned, that we discuss sexual health and dysfunction.
Thanks, Megan. And I think it's really nice looking at those slides. A lot of people have already brought up today some of those issues that we can integrate into one potential care pathway. And maybe we'll discuss this after coffee along with the panel session, if that's okay. So I know everybody's probably looking for something to drink.
Sorry. Okay.